he has been a regular faculty in AO trauma courses, various arthroplasty courses, and he's a very good teacher. To be honest about it, I've learned a lot from him over these years. While every time I interact with him, meet him, it's been real honor and to interact with him. So those who have interacted with him would know that it's vastly experience. So, and I'll welcome other panelists here. Dr. Ranjeet sir, Dr. Ashwini, Dr. Rajiv Kumar Bhatt sir, I think Ashish is here, Rajiv Anand sir, and all other whom I'm sorry I'm unable to take the names. There are plenty of people here, but welcome you all. And without making any ado, I'll just request Dipankar sir to kindly share the screen and start his talk. Sir, all yours.
Thank you very much. First of all, my sincere regards to Professor Sarraf and all the members of the BOA. I'm really privileged to be invited into this meeting as a faculty. It's really an honor to share our thoughts and ideas amongst the group. I hope that whatever I have collected so far, I've tried my best to accommodate most of them within reasonable time. And I will continue periodically with video clips in between the PowerPoint presentations. Please interrupt me if you need any more comments. Just at the beginning, as I told, I'm just repeating to everybody that if there is any by chance, any power failure or net connection failure, just give me a couple of seconds. I should be back with my backup setups.
Sure.
So with this, now I share my screen.
So I'll request rest of the panels and faculty to mute yourself, and if possible, keep your screen videos off so that the streaming can go uneventfully. And all yours, sir.
Is my screen available with everybody?
Not yet, sir. It is. I think it's coming up, but it's you're sharing your screen right now. It's not. Your PowerPoint is not coming in. Sir, I think it will take a while. Just hold on for a few seconds. Yes, sir. Your screen is visible. Your PowerPoint is on the screen. All yours, sir.
All right.
Please make it full screen, sir.
Okay. I've done. So, yes, we begin our journey towards the hip replacement. A new sort of life, the journey to live on with their on. Life is nothing but movement, and movement is a proof of life. So if there is no movement, there's no life. So with this, I'd like to continue. So basically, although it's a meet, I understand there are a lot of PG students also sitting in various parts of the Bihar, Jharkhand, and I have forwarded it to even our students. So the most important learning outcome in today's webinar will be, if I'm able to deliver, that we have to understand the principles here. It is all about principle. If we stick to these principles, it's most likely that we are going to achieve the correct and the best outcome every time. So my message to the juniors, that do not try to be heroic, do not try to be 61st ball. So to understand the principles of THS surgery, get it born inside your system so that you continue to deliver it every time. All these principles, what it does is, it allows you to follow something called evidence-based practice of medicine. It's the most, and I do it this way or you do it that way. There are people who
your sound is breaking, sir. Your sound is breaking.
Sorry?
Your sound is breaking,
Sorry?
sir.
There is something with your audio, sir. It's not clear. So may I request Dr. Shamsul Hoda to take this matter?
Sir, please.
Shamsul, sound is not clear.
Sir, I will request you to switch off your video so that the streaming can go fast.
Yes, sir.
Yes.
Dipankar, sir.
Are you asking me?
Yes, sir. Yes,
sir.
yes. Because I think the streaming is a little bit slow. So if you can just stop your video The rest of the things can.
Well, there is no video running as such.
No, sir. You have to
I've done,
stream.
sir. I've done. I've stopped this video.
Okay,
I've
sir.
done.
It's done. It's done, sir. It's done.
Please go ahead, sir.
Go ahead, sir. Go ahead.
Okay.
Yeah.
Okay. Yeah. So it is the principles are nothing but it is an outcome of consistent practice of evidence-based medicine. So we do it in the technique which has been refined, modified, tested, and the results have been analyzed in a very objective manner. So with the understanding of this principle and implementation of this evidence-based practice, you should be able to perform total hip replacement under watchful eye of yours as well as some of your supervisors, in case of your junior surgeon, to achieve the best possible outcome. Who is a hip replacement? It is the person in whom the hip is not really working normally. He or she requires a hip replacement. What I mean by that? So a hip not working, it may be painful, it may be stiff, it may be structurally deficient, all sorts of things. So we just briefly go through some of the indications. I know all of you are aware, but it is just a run. So it's broken hip, which we commonly fix it or replace it. I am not going into the date of whether we fix it or replace it. For today's meeting, we will consider what are the indications of replacement in a broken hip. The fracture comparison, fracture, the age, we commonly talk about the age, but it is not just the numerical age of 50, 60, 70 or whatever. It is the biological age. That means if the person has restored his mobility and he is able to move in and out of the house and he's expected to do outdoor movements for more than 6 months, that means he has the potential. He or she should be considered for a total hip replacement if he or she has broken the hip. Then, yeah, this is just a picture of the previous one. So it's a distance fracture, so we have practiced total hip replacement. The next, another common indication, all of us to it, fix it with all expectations, but sometimes it do not work. Whatever, if it's a cannulated screw, if it's a dynamic hip screw with a supplement or whatever, conditions really works. So to make the patient back to his or her usual shelf, we need to do a total hip replacement in these conditions. Make sure that this failure of the fixation is not just a mechanical, and it is also the infection factor has to be always borne in your mind all the time as we plan our management plan. So this is a fractured neck of femur fixed with cannulated screw. 3 years down the line, we can see the tilted line. It's not working. Ending up the hip replacement. A similar one, a broken hip basis and say was fixed, but over a period of time, patient shows signs of infection, temperature, raised ESR CRP, persistently painful. Yes, open it and we find that it's frankly infection. So what we did is a two-stage. First stage was block removal, and second stage was implantation after the ESR CRP was normal. This is the final X-ray. Osteoarthritis or rheumatoid arthritis of the hip, relatively uncommon in comparison to the Western world, particularly the osteoarthritis. Rheumatoid is pretty well there. But yes, a painful hip, the person is not able to sit properly, the person is not able to sit in a car or drive a scooter or doing his usual household activities. Yes, that is positively an indication for a hip replacement. That's the picture. So this was another one. This gentleman had developed a vascular necrosis of the femoral head due to some unknown reason. He was seen by some of our colleagues in a different part of the country, and that time a fibular graft, code reconstruction was attempted, but you can clearly see the passage of time, the hip didn't work, the hip got terribly deformed, painful. It was virtually restricting the patient in a wheelchair. So we had done one replacement and he's waiting for the second one. These are the situations when there is no doubt that hip replacement is mandatory. completely damaged hip due to childhood infection. Parents from the northeast of the country have informed that something happened into the hip with some sort of discharge, but they are not sure. After about 20-30 years, we do not get any records, but it's obvious the head has completely undergone dissolution. We check the ESR, CRP, we ask the hip, make sure that there is no present infection. This is the most important thing to determine that whether the infection is present. So we go for in this particular case, single stage hip replacement. This is also an indication for hip replacement as the hip is non-functional. This is something I called a naughty hip. That means the hip was never located inside the socket. Parents didn't realize from poor family backgrounds. The child had limping and these sorts of problems. And finally, it has been diagnosed. A clear diagnosis that the hip was never in place. The socket is shallow. The proximal femur is ill developed in comparison to the other side. So the person demands, I want to walk, I want to go to school. So when I operated him, he was at the age of 17. So yes, appropriate amount of consideration after discussing with the patient, family. So these are some of the common indications we get. This one, as I say, it's an old surgery. It's certainly not a wrong surgery. In some places, these surgeries are done due to availability of resources, due to availability of expertise, whatever you may say. This surgery has worked well, but now it's about 10 years down the line. The lady is surviving pretty well, wants to still talk, go to the religious sort of and everything, and she is happy that something can be done. So after complete explanation of all the consequences, complications, long-term outcome, we converted this hemiarthroplasty into a hip replacement. This is no way undermining the importance of hemiarthroplasty in the management of fractured neck of femur. These types of prostheses are still very much there, and I will never say it is wrong. At least it works as a spacer. It gives patient a reasonable amount of mobility. Even my own grandmother, she would go and survived this for about 7 years after the surgery was done. So the sole purpose of hip replacement today to provide a free mobility to the patient, so the patient can say hip, hip, hooray. That's what is the motto to provide our result. So with this, I go to my first video clip. Just for the second, I will talk through this video. Can all of you see and hear the video, sound, and the picture?
Not right now, sir. No, we can see the PPT. We can see your PowerPoint, but not your video is not coming on the screen. So if you can minimize or share the whole screen again, leave it and share the whole screen again.
I will reduce the PowerPoint.
Yeah. Okay.
And now the video should be there.
Sir, it will
is
take
it visible?
Still not.
10-15 seconds. No, it's not yet. So let's just give 10-15 seconds. Still, your PPT is there. We can see your PPT full screen actually. But
well, I have reduced the PPT from my end.
Sir, can you just unshare your leave it first? I think unshare. Yeah, and now again you share it.
Okay.
Now again you share it.
All right.
Yeah.
How is it now?
Yes, sir. Now your video is on the screen now.
Speaking from Durgapur Mission Hospital.
Can you hear the sound?
Yes, sir.
Yes.
So today we are going to discuss as well as demonstrate the various technical aspects of total hip replacement. So as we do, before we actually go for the surgery, we do something called planning. And out of this planning, there is something we do called templating. That means we gauge the size of the prosthesis is what we are most likely to use. It may deviate, but it's most likely. So what we have done is, this is the X-ray for the patient. We have printed it with 100% magnification. It's an X-ray pelvis including both hips. So for the purpose of the templating, we have to gauge the size of the cup as well as the stem. So how do we do it? First we take the cup. These are the templates in transparent plastic supplied by the companies. We match it against the acetabulum X-ray and see which is the best fit. So let's do it for this one.
I'll just pause it for a second. This is a message to the juniors that templating should be done in every single case. You should do it yourself, record it somewhere in the operation theater board so that you can match what size. You may be, that may become a little bit of erroneous, that's no harm. But the idea of the templating is to anticipate what are the sizes, what can be the possible offset, what are the abnormalities, if anything, you can gauge and be prepared accordingly. So with that, first you do the acetabulum. You take the age of the acetabulum, particularly the fovea, where you should match the lower end of the cup, and after that you go to the femur.
So in this particular X-ray, we do the templating on the normal side, and that's probably the center of rotation of the femoral head, where we will center the cup. So this is the template. It has got various sizes, and we have also another sheet. Let me see which one goes best. So on a cursory look, to me, it appears that the cup, approximately the cup which fits and match with the center of the rotation of the femoral head. The cup is surrounded all around by bone. So to me, this appears to be the best fit. So that's what we're going to use most likely, and that measures 46. Let's see.
The video is not working, sir.
It's not moving. The voice is coming, but it's not moving.
For the stem. So again, transparent plastics, and given the shape of the femur, so these are
guys restart.
I think so. From the template, the moment you have put the template, you can start it from there.
There is problem of network.
Let me see.
Yes, sir.
Yeah.
The video is not moving, sir.
Well, it shows that my internet connection is unstable. This is the real problem.
Yeah.
I understand, sir, completely. No.
The neck will align.
Is it okay now?
Sir, actually,
We
your
can hear
video
you,
is
but
not
no.
seen, sir.
To me, the
It's not coming on screen.
appears to be the best fit.
Just a minute, just a minute.
Sure, sir, sure.
Come on.
In the between, I would like to ask Sudeep, sir, that how frequently do you template your cases?
Yeah, so I was thinking of asking the same question to the panelist. Initially, I used to template, so when I started here in 13 and started operating from 14, so used to template till 17. I did all my templating. Then used TraumaCAD for some time, and then completely stopped templating from 18 onwards. completely stopped it, basically, because trauma CAD, you need to change your, it's a costly software. So Ashish gave me a trick that every time you have to get a new email ID.
Problem is most of the time vendors, they don't supply the template.
Yeah,
no. I have templates, but problem is now X-rays.
Okay, now
nowadays you get.
Sir's video is there. Sir, your video is seen, so we can,
Can you hear me?
Yes, sir, we can hear you. Yeah. But the audio from your video is not there. So
audio from the video is not there. How is it possible? Okay. Let me just.
Now video is there, audio is.
Oh.
So as Ranjeet sir was telling, the issue is definitely
uses of antibiotic, cefuroxime.
Yes, now the video and audio both are there, sir, coming. We can see you templating, so you can.
To me, the neck well aligned. It matches center to center the stem what the head will be. To me, the size 3 stem appears to be the best fit. Unfortunately, I do not have the lateral view so that we could have matched, but normally one view gives you good picture. So these are the 2 sizes I'll keep in my mind, and let's see what it actually requires. Before we actually go into the surgery, we should talk a little bit about some other things. For example, the anesthesia. The patient is going to be having a spinal, and sometimes our colleagues also put epidural along with that, just because of continuous pain control. The patient will be given IV antibiotics. There are various regimens. Some give 1 dose, some give 3 doses. So I normally give 3 doses of antibiotic, cefuroxime, that continues for the first 24 hours. Other than this, in order to reduce the bleeding, I also use tranexamic acid, about 1 gram intravenous. It's given at the same time the anesthesia is done, and that's all. Probably we need to do some work before the surgery. So as we do the surgery, one of the most important thing is patient position, and I recollect from my training days in the United Kingdom, the person who does the surgery, they have to do the position. Although in our busy lifestyle here, or sometimes I must say lazy, we leave it up to our theatre colleagues, but ideally it should be done by the surgeon. And I emphasize particularly the junior PT students, they must know about the position. So what it is, there is something. So I do the deep spin lateral position. The patient should be dead lateral. There are 2 supports, one in the sacrum, right behind the sacrum, and another one, like an L, it supports the ASIS, anterior superior iliac spine. Unless these 2 are rigid enough, the patient might tilt forward or backward, and that will change your cup version, which is going to be damn difficult to assess. So with this dead lateral position, the patient is stable. He has been covered mostly on the head ends. This is something called bear hugger to keep the patient warm. The lower leg has been stabilized on a pillow with some tapes and something along with the diathermy pad, and we just keep it covered with something. And now we can see that the leg is mobile. I will do it anterolateral approach. So it must go right up to the front, and I also need to get some access at the back. So this is the dead lateral position, which is mandatory for a successful hip replacement. So before we start the surgical draping, what we do is just a proper cleaning of the leg, because these patients are there at their home, they are old, and as they come to the ward, sometimes they harbor certain germs into the body. So what we do is nothing but just a chlorhexidine soap and a mop, and we just clean from the top of the iliac wing almost up to the mid leg.
Is the audio and video visible and audible?
Yes, going very smooth right now.
Okay.
Yes.
So now the proper surgical draping is going on. So two members are doing it from the front as well as the back. And the fluid what they're using is 10% povidone iodine. Please note that things are being done from center to periphery, and the groin will be done at the end. Normally, I will recommend to prepare almost from the top of the ilia crest, the umbilical line, and it should come at least up to the ankle joint. Whatever the gauze pieces which are coming to the groin, they will never go back to the incision site. And after this, colleagues will complete the surgical draping. So now we are going to talk about a little bit how to put on gloves. I have seen people using various techniques, just putting a first glove, then the gown, and then the second glove. Well, I think the best, the recommended one by the various international bodies is first you put the whole gown, your hands even fully covered. You must have disposable gowns with cuffs, and I will show you how to put on gloves without exposing. So this is the first gloves which I will use. I'll take the left side first. This is the left side. In the gloves, you just identify the thumb. Where is the thumb? And I put my thumb right opposite to the thumb, and then invert the gloves on top. So the whole hand is actually inside, and then it just slides. I do it on the other side. Now I can touch. Taking it, this is the gloves, thumb. So I put my thumb right opposite to it and invert the gloves on my hand. And then the whole thing just goes in. So there is no touch of raw skin with the outside of the gloves, and it covers the cuff. So now we are almost ready for the surgery. The patient has been positioned, draped. We have checked the consent, we have checked the site, and we have matched it with the X-ray. Our team, all equipment ready, functioning, everything. Anesthetic side okay? Alright. So before you actually put the incision, I always recommend the junior colleagues about doing some landmark drawing. That will make life easier. So I can feel the trochanter here, right up to the tip. So that's the tip. So basically you draw the trochanter all around. Okay. And my incision will be about, it's like a lazy J, normally about 4 to 5 centimeters from the tip of the trochanter, and more or less similar down. So it's like this. This is an advice to the junior colleagues. Don't be fancied upon small incisions. You must do the job properly. You need to have a correct exposure, comfortable exposure. A tissue cut electively will heal much better than tissue stretched. So this is the incision. We just put some cross marks so that we can match it as we close. This is going to be our exposure. So now we really start the operation. please. So some of the bleeding points we forceps. So the skin is done, and now we are just going to give a single incision to the TFL, and I will do the cut with the scissor. Just along the same length of the incision. Self-retainer, please. Scissor. So we have exposed the trochanter, and we have the gluteus exposed at the top, and now we'll go into the next step. So we have the gluteus medius at the top. What we do is at the top of the trochanter, we split it at the junction of 2/3 and 1/3. 2/3 in the front and 1/3 at the back. So basically you can see the fat, and you can put your fingers below. Can I have the diathermy? Yeah. So basically as we lift the gluteus, the idea is to leave a cuff of tissue with the trochanter so that you can stitch it later. So that's what we do. So this is more or less the edge. And I just go a little bit away. Our cut goes along the anterior line of the vastus. Slide external rotation, please. There's a small bleeder, just the diaphragm. Forceps. So we continue with our cut till suction. Slowly external rotate. That's it. So now the hematoma has come. You can see the blood from the inside the capsule is coming suction. And now I do not know whether you can appreciate the tissue which I am holding is the blending of the gluteus minimus along with the top capsule. So we do not go 2 finger breadths above, because then we have the inferior gluteal nerve. So the neck is slowly getting exposed. Now I need a Homan. So this Homan is at the inferior border of the neck. Take it out. Another Homan, please. So this second Homan goes just behind under the TFL, just behind the trochanter. We need a little bit of clearance in the neck. Okay. Yeah. So virtually the whole neck is exposed. Can I get a smaller self-retainer, if possible? And we put this smaller self-retainer at the top for for better visualization. Forceps. So we just release the tissues, a little bit more external rotation, that's it. So almost the whole of the neck is exposed. Can you withdraw the Homan for a second? The reason is I just want to feel the lesser trop. And as I can feel the lesser trop, I plan my cut. The neck osteotomy, there are templates available, but one finger breadth above the top of the lesser trochanter suits for most circumstances. So basically I draw the cut here, and that should be sufficient. Can I have the saw please? So that's the next section. So we have done the osteotomy. Now we have to retrieve the femoral head. So for that we use this corkscrew. Just quickly do a little bit of capsular cut at the top. The anatomy. Head should come out. That's the head. We measure it and keep it on record. So now we have a nice exposure of the acetabulum by just simply correct placement of the three homans. So this one is just over the anterior rim of the acetabulum. This one is just behind, and this one at the top. So basically we have a full view of the floor of the acetabulum, and I can also see the tal, which is difficult to show, but it is clearly visible. For the purpose of the rimming, we will start with the lower one. We have measured the head, which is 46. So we start the rimming now. The first one, the rimmer which I have taken, is size 39. So I have placed it into the floor of the acetabulum. Now two things here. One is an inclination, another is a version. So the inclination is 45 degree. So this is the angle, 45 degree with the horizontal plane. And then for the version, people have confusions. But look, if the patient is dead lateral and we hold it like this, you go this way, your cup remains open anteriorly. So that is anteversion. And if you bring your hand behind, that becomes retroversion. The cup will look back. What we want is approximately 10 degrees of anteversion. So that's what we are going to do. So the rule of hand is we put it into the floor of the acetabulum, and my hand remains more or less directed towards the opposite foot end. So this is the one. Give it a little bit of pressure so that it just right into the floor, and it just rims. Should rim it till we get cancellous bleeding bone exposed. So this is done with the rimmer 39. So now we are at the size 46 rimmer, and I can see that it's really done all along the length. It's tight and it actually matches our templated size. So On the basis of the rimming, I have decided about a size 46 cup. Now we are ready to put the real cup. It's an uncemented one with option of 2 to 3 screws. So we have mounted the cup on its mounter, and now we have to maintain our version as well as inclination. So the inclination is 45 degrees, and I just make the cup a slight open anteriorly. So this is my placement of the cup. It needs a few gentle blows. So I'll just wait for a couple of minutes and then give a little more tapping. It's already pretty stable. Gosh. Can I get that thing just to see that if it is reaching the floor, the screw depth gauge? Yeah, so we just touch it and see it is right onto the floor. All right? Wash. Regarding number of screws, 1, 2 and 3, whatever it is, it has to be very stable. Given the fit, I am quite happy with even 1 screw. Screw depth gauge. Size 25 screw, please. So this is the first screw. Sitting well. Yeah. So just for safety, we give another screw. So we're giving the posterior one now. Size 20 screw, please. So this is the second screw going into the 11 o'clock position. Done. Wash and insert. So this insert has got pegs which should fit with the cup's reciprocal slots. So it just fits edge to edge and just give no. So we have placed the liner into the metallic shell. As we said, the pegs are matching the slots, and just gently tap it. Then we check with a McDonald's is something that is really locked. Yes, it is. So basically we are done with the acetabulum. Now we have the acetabulum done. We are ready to do the femur. The femur is actually flexed to back completely 90 degrees, and the knee is basically being stabilized by my assistant's symphysis pubis, and he's also holding the distal segment of the leg. So we have the proximal part exposed, where we are going to use a canal opener. We should go as lateral as possible, and people also do versions of anteversion, 10 degrees and etc. I normally prefer it a neutral. So I'm just seeing the tip of the, this is the tip of the canal, which is open like an oblique, and then I just open the canal by gently tapping the opener and take the bone piece out. That's it. So this is basically just to open the medullary cavity. It should go as length as possible. One syringe water, please. We start with our first broach, which is size 0. Should go easy. We have got a strong narrow canal, I can see. So now we are using the size 3 reamer, which matches with our templating. You can see that it goes pretty satisfactory. So that's what we are going to use. You can use a trialing right now, but it depends on the person to person. The beginners should use a trialing now. I can do with the original stem because that's not going to change my position anymore. And then we go for the final stem. So this is the end of broaching. Now we have the last number 3 broach, and we have used a standard neck and a head size 32, which is permissible with this system. And now let's see how the reduction goes. Gentle pull, and it goes easy. I will check movement, and my assistant is doing all sorts of rotations. Flexion, please. Extension. Extension. Okay. And in flexion, do some rotations. It will be difficult for me to show, but I can see that it is not coming out. So that is the end of trialing. Real prosthesis. It's hydroxyapatite coated, size 3. So it just goes into its previous broach tag easily. I just give a few taps at the end. Now what I'll do is, I need a little bit of chips of bones to pack the area around the, there is a bit of cancellous bone which is from the very first box chisel which is taken out. So I'll pack it nicely in the gap, whatever is left, and then there'll be a few more blows. Okay. Now the head, please. So this is the original head, size 32. Just a little tap. That's it. And now we go to reduce it. Okay, Partho. Take it out. completely take completely out. That's it. So, okay, please test the movements again. Flexion, extension, go to flexion, do some rotation. I can see it is difficult to show it in the camera, but I can see it is completely stable inside the acetabulum. So that's the placement of the final implants. So now we start the closure. We have given a decent amount of wash. So with the tissue first, what I am holding is the gluteus medius, gluteus minimus, and I take one deep bite here, along with the gluteus remnant inside. It will be difficult to see, but anyway, I just normally put one single stitch into the gluteus. There are people who does it in single layer, minimus and medius. It's up to you, whichever you are confident. And now I will come to the medius. Slightly internal rotate, so that they can see. Now you can see the importance of the tissue cuff, which I had left before for the purpose of suturing. This is the bulk of the gluteus medius. I'm just taking it, and along with the remnant left. Just an egg stitch. You can use it continuous, somebody uses it interrupted, someone drills through the greater trochanter at the edge, whatever. It's your choice. At the end of the day, you need to have a secure closure which will keep the tone of the abductors. That is a main point of success for depression. Hold this. If you use interrupted, 4 or 5 stitches is sufficient. And they always re-emphasize the importance of keeping a cuff of tissue along with the trochanter. Otherwise, it's going to be hell of a job to closure well. You can do it. You can do it by drilling, but you can avoid that. And you can see it is a fairly tension-free closure. Just hold this one. And here, the lower side, you are basically taking a little bit of bite with the tough fibers of the vascus. Well, that's the end of the closure of the gluteus. So we have just closed it. I'll make sure with my colleague that all our counts are correct. Gauze, instruments, everything. Okay. So now we're going to close the TFL. What I will do is I'll just first put a middle one, which makes a position easier. Simple. And the suture I'm using is going for the subcute and the skin. This skin technique I learned from my short experience at Endoclinic of Germany, where the professor I used to work, he was very fancied about doing the whole thing himself till the end. And that's the end of the procedure, my friends. I hope you have enjoyed it. There are many variants which you can apply in your own clinical setup, but as long as you stick to the basic principles, good result is expected all the time. So do one technique, same which you have learned from your colleagues, seniors, teachers, and synthesize one for yourself, and that's what you should do day in and day out. I'll strongly advise that the junior colleagues, you visit many surgeons. There is something to be picked up from everybody, and you take a note of it, which I do still now, and then I come out with one pathway for myself, and which is dynamic, that means it changes, that will continue to change. That's all, my friends. Thank you very much for being with me throughout.
Dipankar sir, are you there?
Hello, can all of you hear me?
Yes, now we can hear you.
Okay, now I'll go to the cementing video, okay?
Sure. Okay, go ahead, please. So in the meanwhile, Shamsul, is there any question coming from the audience till sir loads his cementing video? Is it okay, sir,
Yes,
if we can just take one or two questions if there are any?
Yes, if possible, go on.
So you can share your screen, and by the time, so is there any question coming from audience? Shamsul?
Yes, please.
Can I ask a question?
Yes, please.
Rajeev sir, yes.
Yeah. So Dr. Dipankar is going to use drain. So is it routine for you, or you use sometimes drain or sometimes not?
I normally do not use drain because there have been ample amount of evidence that using a drain or without a drain, the yield, the result is same, whatever parameters you say, whether it's a knee or a hip in terms of post-operative hemoglobin, post-operative hematoma, post-operative mobility, recovery, everything is the same. I have done my own audits, which has been published once into the West Bengal Journal, and we converge with these thoughts that drain is not really of much use unless you expect active source of bleeding. Now, I will say if you have a source of bleeding, you must stop that before you come out of the operation table. That's my line of thought.
Yeah, Dr. Dipankar, I'm Dr. Rajeev Anand. In your video, you didn't take the Acetabulum trial. So you straight away go after
No, sorry. That I didn't take a video of that part, or maybe the person who did the editing, he thought it's unimportant. So yes, I have used the trialing, certainly.
Yeah, that's what I wanted to say.
That one was missed into the video. Sorry for that.
Yeah, right. So the juniors should take the message.
Do you check for combined version?
Combined version. What do you mean by that?
Anti-version of combined anti-version of acetabular cup and femoral neck.
Sir, I use only anti-version into the acetabulum, but with the femur, I will go neutral, because trying anti-version, because whatever you are doing on the table, it's on eye wash actually. You may not know that if the patient is really given 10 degrees and also in the femoral side 10 degrees, you may end up in trouble. Patient tries to sit by whatever means it pops out. So with 10 degrees of anti-version in the cup and a neutrally placed femur, it works well, wonderfully well in most situations. I've never faced any problem.
So
really
that is also one of the beauty of the anterolateral approach, that you have to actually not really struggle with the version. Not really. And you have to actually try and be neutral or slightly retroverted, if not antiverted. So that's one of the beauty of this anterolateral approach.
It is better to keep a bit, I mean, not retro, I mean, less than neutral. 15, not 15 degree, 5 degree, 10 degree is good enough, and your construct is more stable. I have a question.
Anterolateral approach, sir.
Yeah.
Retro version of the cup is a complete
retro version is not allowed, sir.
No, not retro version.
We are not talking about cup. We are talking of, I mean, version of, I mean, the stem.
So stem neutral.
In neutral, anterolateral approach, you tend to be neutral, and in cup also you tend to be neutral, not anti-butted as we do it in the posterolateral. Those who are used to doing posterolateral approach, they try and anti-butt their cup a bit more than what people in the anterolateral approach are.
Yes, in posterolateral you have to be very precise.
Yeah.
I have one question. The approach, Dr. Dipankar, the approach you took is a classical hardings. You didn't take the modified one, isn't it?
No.
Why, sir? Just because most of we usually do modified hardings. But any reason?
No, there is no particular reason. As I said, that you do what you are comfortable with to produce good result. So I am comfortable with this. I do it consistently in all cases, and I produce results. So there's no reason for me to change just for the sake of doing it. Can I go to the cementing video now?
Just hold on, sir. There are one or two questions.
We'll discuss later.
Dr. Rajeev,
sir, please switch on your video.
So, Dr. Dipankar, you showed one case where in your video where there was failure of fibular grafting. So, when finding the femoral canal in fibular grafting, it's very difficult because fibula is very hard bone, tough bone. So how do you tackle it?
Well, that particular case, I had done the neck osteotomy, and I found it's a solid piece of bone into the crossing my path. So what I did is I drilled multiple holes into that cortical piece of bone, and then I just used a bone chisel to take that piece out. That it worked. It came out.
I usually do chisel. Usually sometimes I fear that trochanteric fracture may happen. So I usually do is to take the smallest size of the saw and cut it laterally.
Yeah, you can do that. You can do that. As long as you keep the integrity of the trochanteric region. That's what.
Yeah, means you can use burr, which we most commonly.
Anything
we remove. It's really tough to remove that fibula. It's really
tough. Device to take that piece of bone out.
Any device is sufficient.
Okay.
You have to be very careful with small blade or reciprocating saw blade or a thin blade, because they tend to break also. So you have to be very careful using those blades.
Yeah.
And a little bit piece is left now, so you have to be flush with the lateral wall of trochanter. Otherwise, malposition chances are very high.
Yeah.
Of femoral stem.
So I go to the cementing part.
Yes.
Next.
Sure, sir.
Yes.
Dipankar sir, please switch on video, sir.
Can you see this now?
Yes, sir. We can see the screen we are seeing, not the video as of now.
Please play the video, sir.
Just a minute. Is it coming now, the video and the sound?
No, not yet, sir. So let's give 10-15 seconds more, and hopefully we'll see it.
Just let me know, because
sure. We can see your screen where you have all the videos saved.
So I should start now.
I think you can play the video, but it's not coming up on the screen.
I'm playing it now.
No, sir, it's not. You open it up and then unshare and share it again, I think.
All right. Stop.
Open the video. Yeah.
Okay. Hang on.
Sure.
Where is the video gone? Is this visible and audible now?
You have to share your screen, sir. You haven't shared your screen yet.
Okay, I really do not know what's happening. Okay. I am share screen. So,
Shamsul,
can somebody just guide me a little bit? Well, the last one worked.
Yeah, it worked very well. The last one was fantastic. Yeah, I think it's coming
now,
up.
Now it's there.
Your screen has come. Just click that clip 3 cementing THR.
Yes, yes.
Is it running in the background, sir?
I have just started it.
Okay, so it's not showing up your screen in which you have multiple videos. 8 of them is showing up again. So you have to minimize this screen. I think it is running in the background.
Just a minute. Let me just close the whole thing.
Yeah, yeah. Okay.
Stop sharing. Share screen. Somehow I'm not able to see the video. It should be seen in the screen.
So just sir, open it up and share your screen again. And just leave that window only open and rest minimized in the system.
Let me just close even the PowerPoint.
Yes, yes.
Let me just close the thing also. Okay, now I just have this screen.
Yeah.
Sir, open the video in the background, sir, first.
First, open the video in the background.
Yeah, and then share your screen.
Then come back to Zoom and share screen. You'll see the video button, video window.
This one. So
now come back on.
I have opened the video.
Yes, sir.
Just paused it.
Yes, sir. Now come back to Zoom, sir.
Zoom.
Share screen.
Share screen.
And if you can see the video window in that. And if not, then please go to desktop sharing.
No. Somehow, where is
then go to desktop sharing, sir.
Desktop sharing, which is
this search for the video.
Has it
right
come?
Click, or you can just right click, sir. Right click over the video.
Is it running?
No, sir. Just right click on the video, sir. Right click on the video.
Right click. There is nothing working with the right click.
Okay, just double click, sir. Try again. Double click.
Let me just all videos.
Or if you have the videos in Google Drive, you can share with me. I can run, sir.
Just a minute. Let me see why the thing worked pretty well in the last time. Somehow, Can you see this screen?
Yes, sir.
Yes, we can.
You can see the video screen, sir.
Okay, so
or you can simply do, sir, start a new PowerPoint, put the video there. It will run from there.
No. Let me just double click.
Yes, I think let's give one few seconds before it comes
please
up.
Wait. Please wait. Please wait a while. If your internet speed is slow, then it may take time, sir.
Is it coming now?
Or otherwise, you can just
no,
not coming, sir.
We'll just wait for a few seconds more, sir.
Yeah,
I
please.
think let's wait for a few seconds more. It should come. There is no reason that it should not come. It's just a matter of speed only.
Yes, sir.
The last video came.
So just do one thing, sir. Copy the video from there. Stop sharing, sir. Do stop sharing. Copy the video and put in the last slide of the presentation, sir.
Still, it's not visible.
No, now your screen is
just
unshared.
go to my computer, copy the video, and put drag and drop into the presentation, sir.
Just a minute. I'll just call my son.
Sure.
Sure, sir.
In the meantime, we can discuss some questions and answer, right?
Yeah.
Yes, of course.
So, like, sir, what's the main advantage? Sudeep, sir, what's your experience between anterolateral approach and posterior approach? Like, how do you?
Yeah, so I have mulled over it quite a lot, and my practice is routinely all total hip replacements are posterior approach, and all hemiarthroplasties are Harding's approach.
How to share this video? I want to show.
So it's been that way since almost last 10 years now, 11 years now, and it's just the way I've been trained and seen the stuff. So I continue doing that. I've thought many a times that I will do THR by anterolateral approach because exposure is good, or do my hemiarthroplasty posterior approach, but I have not changed myself because, see, if you are practicing with one particular team, everybody comes to know about your stuff. So I think, of course, there is a theoretical disadvantage, but it has not been proven. And I don't think for me it makes any difference, but I have to be careful in both the approaches of various stuffs. Okay. So,
Rajeev,
have you got the video now?
No, sir. It's just coming up. I think we have to give a few seconds.
By appropriate broach and reamers. The slot has been prepared.
Sorry, I think your sound is coming, but the video is not showing up.
See, this goes almost up to the second mark.
There is a question from YouTube I posted in the chat box.
Yeah.
Ranjeet, sir, are you there, sir?
The whole thing right from the
So the question is, Abhishek, there is a question from Dr. Binay that ideal length of screw superior quadrant for acetabular cuff fixation, and can we take help of Siam to put screws of maximum length and also correct placement of the screw? Okay, so I don't think any arthroplasty surgeon is taking use of a Siam, because see, there are specific quadrants and you put your screws. And minimum is 2 screws. I'll come to that because that I have written it because when Dr. Sen was okay. So now your video is there, sir. We'll continue with the video.
Now we are ready to do the cementing technique. Basically, we are doing it on a dummy model, as we have done the.
Can you hear me?
Uncemented.
Yes, loud and clear, and we can see your video nicely as well.
Bone model, which we have prepared. By appropriate broach and reamers. The slot has been prepared. We have already seen the cuts. So this is the last reamer which has gone comfortably, and we can see this goes almost up to the second mark here. So that's the stem, that's the depth I need for insertion. And before actually the cement is prepared, I'll also make sure that the stem which we are going to use, that also goes the full length, okay, effortless. Now the canal distally is blocked. We have blocked it with a small piece of bone. This is just for the purpose of pressurizing against resistance. So now my colleague Lizo will start preparing the cement. It comes in 2 components. This is the powder, which is the polymer, and this is the liquid, which is the monomer. So Lizo, please demonstrate. You can bring it a bit in the center. So I just want to mention again that cementing depends on temperature of the operation theater. The cement was in the freeze and it has been taken out about 10-15 minutes before. Please note the time right now. Okay, noted. So it will be just gently stirred, and as it becomes an early doughy stage, we will put it into the cement gun. Yeah, as I was speaking, that it is the temperature matters warmer the theater, quicker is the setting. And we keep it in the freeze just to make sure that it remains in its intact stage. It comes out about 15 minutes before, as I have mentioned, and that's the ideal time. So let's see how it goes. You can just do this. Yeah. Is it ready already, Rizu? Yeah. Okay, go ahead, the way you do normally. So as he is putting it, I will mention two things. That we do cementing in the retrograde filling technique. The nozzle will go inside, and just to suck out the air and everything, we put this one. It goes right up to the bottom while the air comes out. And I'll also show one thing. This is a nozzle which will be fitted into the gun, and there is a blue wedge which will block the canal proximally as much as possible. As I inject the cement, this is the way I will do it. Please mount it to the gun. So yeah, I know that people do use cementing by pushing with fingers, but it's always recommended to do it with the gun. So in my watch, it is roughly around 2 minutes. Probably I can just have another minute. So for all practical purpose, with the theater temperature kept around say 18 to 20 degrees, normally by 2 to 3 minutes, the cement is ready for injection. And then we hold it with finger pressure. That's it. So now he has handed it over to me, and I will hold it ready till it is ready for injection. So as I say that I'll do it into the retrograde technique. So push it as much as possible. Pressurize it with the wedge, and then I just inject. And it slowly withdraws. Well, at the end, to some extent, you need to use your fingers. No harm into that. The canal is almost full. Hold, I will take a little bit more. And now I just, in a normal situation, you will be seeing that blood and air bubbling out from here. So I withdraw it. And I can put a little bit cement. I think that's enough. So now normally what I will do is, we'll just use our thumb to hold it. You will feel a bit of pressure. Yeah. Maybe just we wait a minute and then we we use the stem. Well, for the purpose of demonstration, I will be using just a trial stem, and once I have gone into the depth, we will withdraw the thing. So as you enter, remember where your lateral wall is, that's where it should graze. So just push from right into the center. If you have done the broaching well, it should go smooth and simple. You might need a little bit of hammering at the end. Can I just get that scissor, please? So this is just to squeeze. I'm not sure that if it is possible to focus. We have gone up to the depth so that the second hole is there right at the margin of the neck. So I've gone into the appropriate thing. Cement is like a cake, and then you dismantle the stuff. Okay, then there are commercially available pushers, and sometimes people use it. I have seen many times that the people put the head and go for a reduction, which I will certainly not recommend, because all these movements will cause micromotion and that will cause loosening. Best is to hold it stand still. Now, one thing I'd like to show, please leave it on my hands. Into the canal is fully occluded with cement, both below the neck as well as at the top of the neck. Okay, it's very clearly demonstrable here. That's what we should do, hold it in motionless position. If you have gone up to the right depth, then the tip of the trochanter along with the center of the femoral head should be parallel. Just hold it for a few more minutes and your stem is cemented well. Thank you.
Very nice.
So that's the cementing part. Now I will go back to my PowerPoint.
So, sir,
yes, please.
Ask some questions, sir. Sir, like,
yes.
What's your criteria of doing cemented THR versus like uncemented THR? Is it only the age, or like what do you see? You know, like,
look, cemented THR is more of technique. You need to be very precise for the technique of the cementing, which is an art. You have to do this very, very accurately in terms of temperature, pressurization, holding the cement motionless, etc., etc. There is no hard evidence still that the cemented is inferior or the uncemented is superior to the cemented one. If you follow the studies of the Swedish registry, the New Zealand registry, the Australian, the cemented is performing fabulous results, 30, 40 years follow-up. But just sometimes we also get carried over. We learn new things and try to implement new things. And obviously, in terms of technique, the cement needs more precision, and we are becoming more and more T20 players nowadays. We do not want to have that patience. That's why we jump into the uncemented very soon. But truly speaking, it's entirely your call, even for a younger patients. Even for a younger patient, because there are 40, 42 years of results are available from the Swedish hip registry with Exeter's cemented hips. So if you have learned the technique properly, if you can reproduce it, please do it.
All right.
Hello.
Thank you. Thank you. Like,
yeah. So basically, these are some of the just the points to emphasize. I will go back to screen share. So these are just some of the diagrammatic things which I wanted for the junior colleagues to see. They plan.
Your PPT is visible, sir. You
Yeah.
can go ahead. Yeah.
Now there is no, I mean, it's only what I'm speaking. So it's for the junior colleagues that where exactly the neck osteotomy should be done. As I was doing during the real surgery, I have mentioned it was not possible to show you properly. So I've just done these pictures. So 1 finger breadth above the lesser trochanter, that's where your neck osteotomy should be. There's a very, very important technical landmark you should be knowing. Filling the cup or placement of the cup, we talk it anteversion, retroversion, this and that. But look, for all practical purpose, when you place your trial cup, be it a cemented, be it an uncemented, try to just see and gauge from all around that it is equally covered with the bone from all areas, from all sides. If that is so, you know that your position is corrected. This holds true for a cemented cup as well as an uncemented cup. That's how it should look like. So this is just a picture. How do you spread the cement when you do a cementing? You take a 20 gram of cement, when it is just not sticking to your gloves, make it like a dough and put it right into the floor and start spreading and squeezing it so that the cement goes cancellous bony interfaces. That's where the cement must penetrate to have a very, very secure fixation. So these are few technical tips which you must follow if you really want to do the cementing ones. So this is for the neck cut. where exactly the lateral end should be. It should be very, very lateral, and you must place your fingers just below the flare of the greater trochanter so that you know that your edge of the cutting osteotome is almost in line with the lateral cortex of the medullary canal. Because if it is too medial, we'll end up with something called a varus placement of the hip, which is no good. Too much of lateral, you might end up a valgus placement, which will cause thigh pain. So these are just some of the diagrammatic landmarks. It's very difficult to draw these things during the actual surgery, so I just took a piece of sawbone and did this for you. Broaching and placement of the implants. Actually, I should show you this one. There are 3 holes in the broach and the corresponding holes in the main implants. This is very important to set your limb length as well as the offset. This is something you must be very well versed according to the company guidelines which are provided in terms of brochures or PDF files. Your broach should be going, the second one is called the optimum one, which should be flush with the neck osteotomy. And in most situations, that will give you the accurate length, provided you have cut the neck osteotomy well, as well as the offset. And when you do the smooth stem things, most of the versions which are available in the market will have similar markings, and you must be able to match those as you place the real implant. Then only you get the correct limb length as well as the offset. And those two are most important to determine the tension in the gluteus muscles, the abductors, which will give you the stability, correction of the abductor lurch, and a proper gait. So this is very important for the juniors to make sure that they do the right things. So with this, well, now I can take some questions. And well, let me just show you some pictures in the post-op period. This is something I use routinely. We have a rubber wedge to keep the leg like a V in a post-op period, which is the safest position. I just made it with a piece of foam from a local sofa shop. Just wrap it with a water-resistant Rexine, which can be cleaned and washed. And there are some straps, or you can even use a crepe. And that is used routinely for all my cases during the post-op days. And I advise these patients, if they can make it, it's fine. If not, at least they can have a big round pillow, which should be placed in between the legs as they go home. I can advise them to turn on both sides. I have no hesitations, and even turning on the same side as well on the opposite side, as long as that big round pillow is there, which is the safest. When they sit on the chair, I always say that your legs again should be in a V fashion so that the lateral thigh touches the chair handles. That makes the V again in the sitting posture. These are few important tricks which you should incorporate into the mind of the patients as well as the family members, because these are the precautions to prevent dislocation of the hip. So this should be instructed. So I normally go for an early full weight bearing rehab for cemented as well as uncemented. Many times I hear this question that how long the bed rest, Dr. Saab? I said no bed rest, and patients get surprised. मैंने सुना 3 महीना 4 महीना 6 महीना. I said नहीं. अब देखो, you will walk back to your house, you will walk up the stairs, you do not need any help, and actually you can walk in your garden the very next day. So I take them out of the bed within the very second day. Sometimes, of course, if the ladies, they are too feeble, okay, for the purpose of the pain, you give 1 more day. But everything has to be completed. That means walking 30, 40 feet in a corridor, going at least 10 to 11 steps in the stairs, and also able to sit and get up from a commode. I advise them that when you tell the patient that what should be the height of the commode, normally the commodes which are available in the market is 19 inches. And I say that you just ask them to put a wooden platform or a brick platform to make it 23 inches. If that is not possible, buy a new commode chair. So these are the advices I give to patients for prevention of bad postures or unscientific postures, which might end up with a dislocation. So yes, now I can again take some questions if you have.
Thank you, sir. So I think there was a question in the chat box about how long should be your screws and how many screws do you put and where do you put it?
Well, in the uncemented acetabular cup, I believe you mean.
Yes, yes, of course.
Okay. Well, normally The first important thing is the cup, as you place into the acetabulum, it must reach the bottom. And that you check with a small, the depth gauge, the central hole, which is normally kept for this purpose, that it is touching the floor.
Yeah.
And then once it has touched the floor, you are very secure. In order to prevent rotation, in most situations, I will say 2 screws are sufficient. I normally prefer the screws, suppose if I'm looking from the face, at 1 o'clock and the 11 o'clock position, because the 1 o'clock position screw, provided the cup is placed really well, it gives a long screw of around 25 millimeter. I measure it. In most situations, it's around 25 to 30. And the back screw, which is at 11 o'clock or 10 o'clock, it's normally around 20. So with these 2 screws, you get an absolute stability. Exceptional situations, I have come out with 1, but for the purpose of training to the juniors, I will say go for 2. No compromise.
Yeah, so because the rotation will be blocked if you are at all using the screws, the idea is to prevent the rotation of the cup inadvertently till it incorporates into the native bone. And 1 screw is a big no-no, and minimum of 2 screws. And there are times when you have
minimum 2 screws. Yeah.
So, sir,
minimum 2 screws.
So, can I ask a question, sir?
Please.
So, like,
yes, Abhishek, please go ahead.
Sir, is there any difference in the reaming technique between, you know, like cemented and uncemented total hip replacement? And like, suppose the head size is of 46, then like from what size you start, and what is your first size you start with your reaming, and what is the position of the reamer which you use, you know, like in the first reaming?
Okay. So, well, what is the purpose of the reaming? The purpose of the reaming of the acetabulum is to produce a bleedy cancellous bone all around to get incorporation of the uncemented cup as well as the cement. So we have to achieve this all around. The first reamer, normally you take a relatively smaller one because we have the foveal gap at the very bottom, and normally it is covered with a thick fibrous tissue. So if you really take a, say, 44 or something, that will not go into. So in order to flatten that depression in the very center part of the acetabulum, normally you start with 39, in most of the situations 39, 37, 41. These are the starting reamers. Once you have done this, you will find that this elevation has flattened, and now you can go for the higher ones. As you said, what position? The position, as I had showed you, inclination 45 degree and anteversion of 10 degree. Depending on your thickness of the bone, depending on all parameters, you might have a thought of medializing the cup in order to make the abductor mechanisms efficient. But I will say that do not go too far, because in our Indian, particularly the woman, I have seen that in attempt to do medialization, we have breached. And sometimes it's a very thin shell of cortical bone. So I really do not attempt to go too far medial. Only the first reamer, I just attempt to be flat on the cortical bone surface. And after that, I just concentrate on reaming progressively the peripheries. How far you should ream? Again, that depends on the company. For the cemented ones, whatever the size of the cup you have decided, you must keep 2 millimeter of mantle. So if you have a 43 cup, you're going to say, so normally you need to ream probably up to 47. So we have 2 millimeter reamings all around, 2 millimeter of cement all around. Regarding the uncemented, the company have specifications. I will not name any particular companies, but there are in which you ream up to say 50, which is ideal for jamming a 52 cup. And then also you have companies which have a 50 reamer and you put a 50 cup, like in this particular case you have seen, I have reamed up to 46 and a 46 cup has been tightly fit into. So this is something you not just need to follow the company specification.
So I want to ask a question.
Yes.
Yeah. Dr. Rohit Boss, please.
Thank you very much. So I wanted to ask that many a time there is a lot of osteosclerosis while reaming. So even after reaming, say for many times and for a long period of time, we don't get that cancellous bed in in a few patients. A lot of patients who are having sclerosis, joint sclerosis, periarticular sclerosis. So a lot of times we don't get that bleeding surface and what we are looking for.
I know what you mean.
Yeah.
In these situations, probably the reamer is not sharp enough. I had these problems in the beginning of times, and I have seen the companies which sometimes they provide the reamers that has been used hundreds of times, and it hardly scrapes anything. So first of all, check your reamers. Normally a reamer provided by the companies is good for about a certain number of cases, but you know, in our country, everything runs. They just continue to use it till somebody just really throws it on the floor. So make sure that your reamer is sharp enough. Number one. Number two is, if the reamer is not sharp, you know what happens? As you're putting more pressure, you are actually breaking the subchondral calcaneus bone and pressing the cortical bone onto it. So you will never actually take out that cortical bony shell to expose the cancellous surface. The cavity is going to be deeper and deeper and deeper with your axial pressure. So in these situations, it is the sharpness of the reamer, and probably it is the first reamer is the most important, because if the first reamer opens up the cancellous bone and the second, third ultimately course it out. So that's how I, yeah, Sudeep, you want to say something?
Yeah, so if you are really stuck into the situation when you're given a bad reamer and you can't get a new set, so which we all have faced in the earlier part of our careers, then small gently make some cuts with an osteotome. Just gentle few cuts in the osteotome so that your blunt reamer can bite. So that's one thing that I have done in the past since an earlier days, that small gentle nicks in the sclerotic part so that your blunt reamer can now take a bite into it. And once that, as Sir said, once the first layer is gone, then there is no bigger issue once reaming. But yes, your question was very valid actually to the younger colleagues who will be getting the worst set available in the town.
Sudeep, here at Patna, most of the time reamers are blunt.
Yes.
Sir, one question.
Shashikant, go ahead, Shashikant, please.
Regarding question asked by Rohit sir, it's well explained that many times, like post-tubercular cases where anti-tubercular treatment has been completed, or in cases of say avian, where we know that sclerosis is there. So even despite having good quality reamer, we are having problem of that bleeding surfaces. And in that cases, I suppose that coating of what we say cup matters, which helps in osseointegration. So it's, I think, well described that sclerosis is a known problem, and many times it happens that even despite having best of effort and best of instrument, we can have non-bleeding surfaces.
Correct.
And
correct.
in those cases, in those cases, that classical cup which we are using doesn't osseointegrate, and for those we have to opt for that coating where osseointegration.
Yeah, so in these cases, you have to have two things: low threshold for cementing. So that is very important, that you need to have a low threshold to cement those cups. That is very important. That if you are not getting a good quality bleeding, then you need to check your blood pressure with your anesthetist as well. If your mean blood pressure is too low, then the patient will not ooze also. So that is another issue. So these things need to be checked, keep low. And then if you really want to go uncemented and you have planned well in advance, then you can go with a higher quality cup like Gription cup and a better surfaced cup rather than your routine grit blasted cup. So grit blasted cups will definitely not work if the bleeding is not good. So my take will be check with the sorry. Yes, Dipankar.
Okay. Well, at the end of the day, whatever cup you have, whatever system of fixation you have, cemented, uncemented, grit blasted, etc., the bottom line should be having a bleedy bony surface, bleedy cancellous bony surface. If that is achieved, cemented, uncemented, everything will work. So you must work hard to get this goal, that I have to have a bleedy cancellous bony surface. Check your reamers, follow whatever techniques you have. I will say, do not rely on the implant to provide you stability. You more rely on your own surgical techniques to have the stability. An implant will fail by any means. No coating, no blasting, no screw will give you optimal stabilization unless bony integration either with the cement or with the cup surface takes place. If any one of you have ever visited DeVos, the DeVos laboratory have a beautiful microscopic sections of acetabulums with cements as well as metallic things where they show how beautifully the bone grows in between the screw edges, in between the tantalum wires of the shell, and etc. They say that this is the stability factor, not your grid blasting or this and that. It is the mechanical interlock between the cup material and the bone.
Ashwini, you have a question, Ashwini?
No, sir. I would just like to share an X-ray and just have an opinion of Dipankar, sir, since on that. Okay, if that is fine, can I share?
Yeah, of course, please. Go ahead.
Sir, this kind of acetabulums that you get, sir.
Yeah.
Sometimes this is all. I have seen this much of sclerosis in many like primary osteoarthritis kind of hips that we get sometimes, and they do have a lot of sclerosis that actually cannot be removed just by a reamer. And then again, doing cemented hips in these, actually these are pretty young patients too. So now it becomes a little tricky whether to go for a cemented one or to just keep on reaming and put a jumbo cup. I don't know. I'll just share what I did.
Yeah.
Like a few times, if the bone is not, I'm not able to actually remove all the sclerotic bone, as Dr. Rohit Lal was just asked. So these cases usually need some kind of bone grafting also, as the hip center has moved up. So I just I ream as much what I feel is good enough. Then at least 50%, sometimes the anterior wall or the posterior wall, I get some kind of bleeding bone. Then we just put some holes in this sclerotic bone, like 10, 15 holes. Then we put a layer of bone graft, then reverse him, then put a cemented cup and just hope that it all osseointegrates. I don't know. Like, can we do that thing? Or...
Okay. This is the case where you need the importance of the pre-operative planning. I will take it this way. I will do a CT scan on this one. Okay. And with the CT scan, with the softwares nowadays, actually you can exclude the femur. You can take the femur out by 3D orientation, blah, blah, whatever they do. Have a decent measurement of the cup in the CT. This will no doubt a bit bigger, but not the jumbo. Most of these ultimately will find, even in your practice, you will be pretty good with something around 52, 54, something like that in most situations. So once you have got the CT scan done, at least you have an idea that what size cup possibly we are, because normally whatever the companies provide, they have a window. They give from this to this. You do not have these extremes. So anyway, with the CT scan, with the measurements in place, you prepare your inventory. What's that? You think about that I might need to use bone graft. Where from that graft is coming from? It might come from the iliac crest. It might come from that neck and the whatever segment of the head is there. And if you have access, you can think about bone bank and these, but these normally do not integrate well with live bone. For all practical purpose, iliac crest or the segment of the neck, you can nibble it into small chips, and that, so your bone graft is ready. You keep large cemented cups, no problems. Uncemented, most of them will be having these 52, 54, 56, the so-called jumbo cups. And if you really find it is going almost up to 58, you can even talk about, this, what you was talking about, this wedges and those sorts of things. But as you, this has also got a bit of protrusion. But Once you have removed the neck osteotomy, you have placed your Homans. First, I will advise that you use the curettes to clean all the soft tissues. And these are the situations where you do not start with a 39 reamer, because the cup is pretty big. If you use a 39 reamer, you'll be bang into the pelvis straight away with the first reamer. You need to have some sort of resistance. For this particular one, probably I will have a start with something around say 43 or 45. And then if it goes up to 50, 52, I think I'm quite comfortable with uncemented as well as cemented. If you have cemented in the sizes of in the range of 50, 50 plus, then Smith & Nephew or some other companies will have 32 size heads. So this is also something you have to think of to keep your inventory. Other than this, if you're really worried about the integrity of the medial wall, you might keep all this mesh and shells and etc. But really speaking, I have gone through these types of cases at least 5 to 6 times, and I can come out in most situations. I am yet to use all these Gibson cells and etc. with a large head, something around 52, 54. That's it.
So we can reconstruct the wall with the femoral head.
Yes, you can.
That will be, yeah.
So the center of the femoral head, that has to be parallel in comparison to the opposite side. So you will have more bone gaps superiorly. That can be made up with that large chunk of bone removed from the neck that can be sized, fitted with screws, and then you can put a reamer.
Yeah, and reference with the transverse ligament, acetabular ligament, the lower limit, and go on increasing the size of the reamer. Till so we can use then normal cup, normal size cup, opposite side cup. Yes, same size as the opposite. Yeah.
You need optimum stability at the end of the day.
So my question is now, in protrusio, which one is better, cemented cup or uncemented cup?
Both are equally well. In the protrusio, you have to decide that what you have inside. Is it an intact piece of bone? Is it just a cortical shell? If that is there, it's a gift for you. Do not disturb it. Do not go for that small first reamer. That will breach that small shell of bone. That shell of bone can work wonderfully well. It's a contained bone defect. You pack it with bone graft or cement or whatever. Do everything to preserve that intact cortical shell inside. That is your make or break. So use relatively larger reamers so that you can
peripheral rimming.
Peripheral rimming, peripheral fits. And then as you're using an uncemented, you have sufficient amount of bone, I believe, from the femoral head, and which you can put into, take a relatively smaller size reamer, turn it into the reverse direction, jam it, and then on top you can put an uncemented one. If you do a cemented,
But in any arthroplasty cases, now where there is protrusio, which usually is there, so you don't have bone graft there.
Post-op, you mean already a hemiarthroplasty?
Yeah.
Bone graft. Well, these are the situations where you need to keep either bone graft from the iliac crest, or you can get bone from bone banks. We had situations like this, and we keep 2 or 3 bones from bone banks, keep it, and we use that in those situations.
One question from my side, sir. In a complete ankylosed hip, sometimes reaming, when you ream it, then you don't get the whole shell of the head of the femur. The outer shell you don't get in toto. So sometimes it is very difficult, like whether your reaming has been completed or not. So any tips of that reaming in a complete ankylosed hip?
Yeah, I know. What you mean is that the femoral head is virtually merged. I mean, there is no plane to negotiate in between.
Right.
All right. Well, if you carefully look all around, just by placing 3 or 4 Homans, try to have at least one. You will almost in all cases will find one particular area where you can negotiate some sort of carved osteotomy or something to have an idea when that ankylosing is. Normally, in those ankylosing situations, the most of the ankylosis process takes place superiorly and posteriorly. So if look for interiorly and inferiorly, you will almost inevitably find a plane where you can negotiate an osteotome. All right, That's one thing. So that's where you can use a curved osteotome, take that chunk of bone out, and then be very, very slow. If you want, you can use a smaller osteotome and take, or nibbler or something to take the bone pieces out. And then do the reaming under radiological guidance. You take an X-ray before, keep it in the store, and do the reaming in radiological guidance. You will find that at some point, you're obliterating that femoral head's shadow. At that point, you know that you have passed the femoral cortex and you are getting into the acetabulum.
Right.
And you will get a small fat of pad once you enter the fovea, once you have in the center, so that you can know that you have gone.
That fovea is actually the area where in most situations you'll be able to find a space to negotiate your osteotome.
Yeah, so, sometimes we get the shell of the head of the femur, but most of the places it is deficient also. That's
to clear the pulvinar is the most basic thing one has to do, because by that you know where your medial wall is, and that is the clue that gives you, okay, no, this is the final wall. I don't have to breach. Up to this level, I have to go, not beyond that. So clearing pulvinar is very important. In this situation where you don't know where is what is where, you are unable to know where the medial wall, other things are, okay, you can increase the, size, but medially you can't go. So you have to know, you have to identify the medial. And in this situation, is closed medial wall is, this cotyloid fossa is full of fibrous tissue and etc. You have to clear it by the first reamer, which goes straight 90 degree, and then you scoop it out. And once you have got this, you are there. And that is
in most situations. It will not be completely clueless. In most situations, there will be something left for you.
Yes, sir. Yes, sir. I do agree.
So that's what my question is: should we use the osteotome or the curette?
Yes, a carved osteotome, a gentle, fine carved osteotome. Go slow. The advantage of the osteotome is it's entirely under your control. It takes the shape, and also, of course, you can take a curette. Be slow. Be slow. Take bit by bit. You do not need to take a large chunk at one shot. Okay, it will take another 10 minutes, but take it small pieces. No problem. Nobody is going to blame you for that. But you can curate it out. You can osteotomize it out. Do it slowly. Do not breach the cortex medially. That will just jeopardize your strength of fixation.
Actually, don't try to lever it out a big chunk. Because most of the times these bones are osteoporosed also. They are fused, ankylosing spondylitis. The bone is, weak, osteoporosed.
And I will also say one thing, like if you have the shell like this and your osteotome is going this way, do not lever it like this. You will break up this edge. So you rather, once you have negotiated the osteotome, you just do it this way.
Yeah.
Okay. If you try to do it the other way, you will almost inevitably end up breaking something.
That's the thing I was pointing to.
And if the situation lies that if the part of the head remains there and all the surfaces are bleeding, can we stop there and fix it up?
No.
Not really. Not really. If the part of the head remains, what do you mean? You can at least nibble it out. You can use a sharp nibbler, everything to just take it out, small pieces, piecemeal. Take half an hour extra, but take it out. There is no way that can stay. You can beat it at any way.
Yeah. Even if the head and the acetabulum are totally fused means bony ankylosis complete. Even then, you have to find the proper place of acetabulum where the acetabulum lies. Otherwise, the end result, long-term result will be poorer.
I was lucky. I had the opportunity only once in my life to watch a surgery of converting a hip arthrodesis into total hip replacement. That was again during my training in the UK, and it was Professor John Robinson from Exeter. Beautiful surgery, I must say. So there was a continuous trabecula from the iliac wing right up to the trochanter. All right. So he has cut the neck flush, cleared the neck at the back. The capsules and everything were all stuck. So anyway, at the end of the day, I am looking at a acetabulum shaped structure with solid bone.
Yeah.
There is no, like acetabulum, you see a socket, isn't it? So there is a solid bone. So what he did, so he took again the smallest tumor. So acetabulum is being created. So first a little hole, then another one, then another one. But surprisingly, when it went right up to the end, we found that at the last bit, I will say of the total surface area, some 20–30% of the surface area's femoral cortical surface is still there. That means the ankylosis has taken place. If you consider the total surface area, that 30% is still joined.
Yes,
so that was wonderful to see.
Yes.
Sir?
Yes.
I'd like to share my experience, sir. So when I was there in AIIMS with Malhotra, sir, he was doing an ankylosis test. Sir, actually, one study was going on in which where complete ankylosis in case of ankylosing spondylitis was there. He used to say two things are very important. Number one, you should use image intensifier whenever in doubt.
Yes, of course.
To locate. That is point number one. And point number two, first identify pulvinar inferiorly, where whatever ankylosis is there at inferior part, there must be pulvinar. So you have to locate it, just identify it, and then start reaming. One question which Rajiv sir asked, when we found adequate, say, acetabular shape, but still some bone is remaining there. So he used to say superiorly and posteriorly, sometimes or most of the time, in case of ankylosing spondylitis, there is complete bone.
Yeah.
Even cartilage gets ankylosed. So if you are getting adequate bone and you have
bleeding also.
Bleeding is there, and radiologically you know that bone is totally ankylosed. Then particularly superiorly and posteriorly, and in inferiorly you have reached at the pulvinar and medial wall is intact. Then there you can go for it.
Yeah, that's what some of the literature has mentioned that, and I have come across one case. That's why I have asked it. So in that case, you can go ahead.
Basically, you have to clear the cotyloid, clear the pulvinar, reach the medial wall. That way, you are restoring the normal center of the, hip, or nearer to it, and that is very important. So you cannot leave it go. You have got the whole cancellous surface. They are fused also. So better apply. So what will happen? Your hip center is lateralized, and that is, if that is not acceptable. If I can do it, you should do. I will restore the center of the normal hip, as much nearer to it as possible.
Look, these types of cases, I will say that as we can see from our discussion, what makes or breaks is pre-operative planning. These are the cases you just need to sit with a cool of your mind, think what I'm going to do, write the steps. Sometimes, like the AO said, that what I'm going to do first, second, third, what are the inventories required, keep it writing, and then maybe you just hand it over to your nursing colleagues and everybody in the day earlier so that they also read, they know what to expect with your assistance. Pre-operative planning in these difficult cases is the most important thing. You need to have steps to do. You need to have adequate equipment, logistic, infrastructure, C-arm, bone graft, wages, whatever you can say, because we work in a place not like endo clinic. They have everything on the shelf. Okay, ye le aao, wo le aao, sab aa jayega. We do not have a second size cup sometimes. If you practice, say, I work in Durgapur, it's about, say, 200 kilometers from Calcutta. They bring only one size. So there is no backup for if things fall apart. Of course, now we have a little bit of more infrastructure. So planning. Ankylosing means iatrogenic injuries during the surgery. That iatrogenic injury can involve the acetabulum. That might jeopardize your fixation. That iatrogenic injury might cause problems to the femoral shaft. You might end up breaking it by some means. Everybody has done it. So you need to keep these rare situations in your mind. Long stem, that plates, etc., etc. for ankylosing cases or difficult cases. So that's why I say pre-operative planning is the most important in these difficult cases.
So regarding case which Ashwini has showed, that we found that initially, inferiorly osteophytes is so much so that we may actually get confused that this is the floor. And so you said ki in these kind of cases, we can start reaming with 43. So initially, I have found that when we are starting with larger reamers, sometimes we end up reaming higher with high hip center. So isn't it okay to start with 39, go up to the floor inferiorly, and then gradually start with the large size reamer?
Yes,
so I think what he meant initially was that you identified the floor, and once you have identified the floor, you have to cover the whole surface, the whole hemispherical surface.
Floor or medial, yeah.
Okay. One more question, sir. Regarding
question go on. So we need to stop now, no?
Well, I'll just have some.
It's endless.
No. Regarding the topic which has been asked, actually there was one question. Abhishek asked one question regarding choosing cemented or uncemented. So particularly in elderly cases, say 75, 80, where osteoporosis is very evident, don't we go in favor of cemented as compared to uncemented so that we can mobilize a patient early?
Sorry, just summarize and repeat the question, please.
Yeah, regarding cemented and uncemented, in cases of elderly patient, where evident osteoporosis is there and we are going for THR, in those cases, isn't it that doing cemented is better than uncemented so that we can mobilize early? We can rely cementing on cementing in elderly osteoporotic patient.
Well. The results of cemented or uncemented fixation in osteoporosis are same. It has been seen everywhere in the world. The rehabilitation, you cannot compromise on that elderly person to sleep, to lie in the bed for another 3 or 4 weeks or whatever. When you come out with a hip replacement, your writing should be that mobilize tomorrow, full weight bearing, unless other problems. Yes, he might have a blood pressure problem, he might have a visual problem, he might have blah, blah, blah. But your fixation, arthroplasty is fixation, secure fixation of the implants. Your fixation, cemented, uncemented, osteoporosis, osteoarthritis, whatever, must allow full weight bearing rehab the next day, 24 hours.
Even in uncemented.
There is no place for delay even in uncemented. I have asked this question to Professor Zweimuller. I've asked this to many stalwarts. That total weight bearing fixation next day. Otherwise, what is the purpose of the operation?
Yeah.
The last question is the uncemented, sir. If the both the screw hold is not good, should we wait mobilization or not?
No. Why the hold is not good? Why the whole screw is not good?
Sometimes in osteoporotic patient,
if you have the
no press fit, there should be press fit of the cup.
Cup is press fit. I'm talking about this screw.
Then forget about the screw.
No, if the cup is press fit, if your first screw is not good, then you still have 2 more screws.
Yeah.
You still have 2 more screws. So make sure that they are correct.
Can I say something?
Yes.
Yeah. What I do, because most of the Indian patient bone quality is not so good. Yeah. The thickness is not also very good. So what Dr. Rajeev has told, it sometimes happens. So for that, what I do on right side, the 12 o'clock hole, I just simply rotate, bring it to 1 o'clock. While on the left side, I rotate it and bring it on the 11 o'clock. And then most of the time, my screws are longer in length and the purchase is very good. And the 12 o'clock, which is now 11 or 1, I usually 35, 40 maximum I can get. I take the help of sometimes if I am in doubt, CR, whether I am going heavier this way or that way or not. And then I try to keep put a longer scope.
Larger scope.
And most of the time, I am able to get good purchase of this.
I think, sir, we have surpassed the time limit of our webinar. So I think if we have any quick questions.
That's the last slide from my side.
Yes, sir. Please go ahead.
So I will say, can you see it now? Yeah.
Yes, we can.
So this is for the junior colleagues sitting in every part of the country, that when you talk about hip replacement, you must be having a correct selection of the patient for the surgery. The patient selection indication must be evidence-based. You stick to the standard operating practice principles. Do not try to be innovative engineers at the very beginning. Do not try to hit a sixer in the very first ball. I know the T20 is the popular form today, but still the best batsmen are those who have played the test cricket well. So learn the principles and apply it. Both cemented and uncemented have excellent outcomes. Don't be carried over by the company, by this and that. Excellent results, equal results are available even today with cemented and uncemented. It's just a matter of technique and correct application. And then you devise your own pathway by learning from people, from colleagues, from juniors, from seniors, from everybody. So there is something, everything to learn. So incorporate all of them into your practice and have a pathway, and that should evolve, take you through your journey. Thank you very much, my friends. That's the end of my presentation. I hope you had enjoyed, and I think we can.
No, we definitely have enjoyed, sir. It was a very lucid presentation, a very nice videos, both of them actually. It was wonderful having you on board and getting your experience shared with us and answering all the questions all around. Some nice discussion, Ranjeet sir, Rajiv Anand sir, Madhusudan sir, Rajeev Bhatt sir, Rohit boss, and other colleagues, Ashwini, Keshav, and all. Ashish is also here. So we had all around discussions. Abhishek is there. So thank you very much, sir. And we hope to get you again in future for some or other webinar, because I know that you are a very keen teacher and you make very nice videos. You're very much into teaching and learning. So we'll be looking forward to host you again in Bihar Orthopaedic Association webinars. So all yours, Sarraf sir, and to say final good night to everyone.
Thank you. It was quite interesting, informative, and interactive session. Thanks to our faculty, Dr. Dipankar Sen, and a special thanks to Dr. Sudeep, Dr. Ranjeet, Rajiv Anandji, Ashwini, Gaurav, and everyone who have attended this session. I hope in coming weeks we will continue this series, one speaker, one talk. And excellent. I hope for the best. Thank you. Thank
Dr.
you.
Sarraf, just one last request from my side. Could you please generate a certificate sort of thing for this meeting? Because that will be adding to my teaching credentials. Right. As
we have discussed this in the last meeting as well, online meeting, and we are trying to get online certificates for the faculty and participants, and we'll be sending you in due course time. We discussed this in last week as well.
I can design one certificate for that. I can do that part.
Yeah.
Thank you very much.
Dr. Shamsul will help in this regard.
Yeah. Thank you. Thank you very much.
Thank you.
Have a nice evening.
And good night to you.
I request our secretary, sir, Madhusudan sir.
Madhusudan sir, please final word before we wind up.
Thanks, Dr. Shamsul. Really, this is a very nice discussion. I would like to thank everyone for their time and efforts. It was a very educative and interactive session. I give a special thanks to Dr. Dipankar sir, who demonstrate us very nicely and everything, very basic things like the position of the patient, how to use the gloves. Everybody know, but he demonstrate how to use the gloves, how to use the cautery, how to dissect, neck excision, acetabular visualization, and how reaming, how to make the cement and inject, everything, the basic things. These are the very basic things, and every surgeon need to know. We hope it was very beneficial for all the blooming doctors in our association and all over the country. Lastly, I give thanks to our respected President, Dr. Sarraf sir, who has chosen this topic. Thank you, sir, and thanks to all of you for this nice discussion. Good night.
Thank you.
Good night, everybody.
Thank you, sir.
Thank you.
Bye, everybody.
Good night.
Right, sir.
Thanks a lot, sir. Thanks from IoT TV, Ortho TV, sir. Thanks for
Thank you,
being
Shamsul.
here.
Thank you for a wonderful
session, sir.
hosting as always. Behind the scene, man. Thank you very much. Wonderful, Shamsul.
I think Shamsul is busy from morning till night.
Yes, sir.
Yes, Shamsul. Huh? That's
Amazing.
wonderful,
Hats off.
amazing. Yeah.
Hats off to you.
Thank you, sir.
Chaliye. Thank you, sir.
Thank you.
Ranjeet sir.
Thank you.
Sarraf sir, good night. Abhishek, good night.
Good night.
Rajeev sir.
Request all to join tomorrow for Bihar Square Society meeting tomorrow evening 7 p.m.
But certificate is one thing.
Good night, sir. Good night.
Certificate is one thing, Madhusudan sir and Sarraf sir, that we